Welcome to the Narrative-Based Medicine Lab for the NBM Talks series. I'm Damian Tarnopolsky. I'm the creative lead of the lab.
And I'm Karen Gold, the curriculum lead at the lab.
We're joined today by Allan Peterkin. Dr. Allan Peterkin is Program Director at the Narrative-Based Medicine Lab. He's the founder of the Health, Arts and Humanities at the University of Toronto and served as inaugural humanities faculty lead for undergraduate medical education, postgraduate medical education, and continuing professional development of the Temeti Faculty of Medicine. Allan is a true pioneer in bringing narrative practice approaches in healthcare to Canada, with countless accomplishments and activities, including co-founding Creating Space Canada's annual medical humanities meeting, the Canadian Association for Health Humanities, and the award-winning Canadian literary journal Ars Medica. He's the author or editor of 14 books on medical humanities, narrative medicine, physician health, cultural history, and human sexuality, including Staying Human During Residency Training, and an acclaimed collection of patient narratives called Still Here, a post-cocktail AIDS anthology. Allan is also a Distinguished Fellow of the Canadian Psychiatric Association and Senior Fellow at Massey College, and was most recently the winner of the US-based Health Humanities Consortium Visionary Award in 2023. We're delighted to have you with us. Welcome, Allan. Thank you very much for being here. And to begin this conversation, we're hoping you could tell us just a little bit as an introduction, your background, your medical studies and career, and what brought you to narrative-based medicine.
Well, I'll go way back. So my father was a family doctor, my mother was a writer. So I think, and throughout my career, I've tried to bring those two strands together. And I've always been interested in writing. I wrote right through medical school. I've published my first two books during residency. I think I was the first person at McGill. I did a joint residency in psychiatry and family medicine to ask for a writing elective. And they'd never heard of one, but they let me do it. And it resulted in a children's book and then Staying Human, which you mentioned. And that book, Staying Human During Residency Training, is now going into its 7th edition this spring. So it struck a chord. And it's interesting, I wrote it as a trainee and then changed it as I became an educator and supervisor and so on. So, yeah.
Can you tell us a little bit about how, in your life as a psychiatrist, how narrative approaches, methods have really sort of informed your clinical work?
Yeah, well, I was trained as a psychotherapist. We had a very strong psychotherapy program at McGill. And psychotherapy is narrative medicine. It's, the building of a story together over time, meaning making over time through dialogue, respectful dialogue, and close attention to language, because language really matters in literature, but it matters in psychotherapy. And we've come to realize it matters very much in any examining room with any clinician, that words matter and stories matter. And so, as I taught medical students, we were always said you have to take a history. I said, well, look, what we have to do is receive a story. And one of my mentors was my Aunt Edith, who was a pediatrician. And she was one of 3 women in her class back in the University of Manitoba when there were quotas on women and Jews in many schools across our country. And, she said to me, Allie, she called me Allie, doctors are always talking about, we have to solve that a patient is a problem to be solved. And she said, we really need to think of patients as a mystery. And I think if you come with that kind of curiosity and humility about a patient encounter and receiving their story, that builds alliance and trust and better care.
You've been and continue to be at the forefront of this work in Canada. You've worked in the United States in narrative medicine with colleagues in Europe and in the United Kingdom. How do you see the state of this field today, and what do you see as the forthcoming challenges?
Well, the movement began in the UK at about the same time it started in the US at Columbia University. And I attended one of the very first workshops at Columbia and have enjoyed a really great relationship with Rita Sharon and her team. But back in the day, I think those of us in that class, we were all physicians, and I'd say at least half of those physicians were burnt out. So they were trying to find a way back into their work, that it wasn't rote, um, I think that's what drew people back to it is, bearing witness, honoring stories. That makes each encounter kind of new. And, as I said to students, who are going to become internists, you're going to treat 500 cases of congestive heart failure. But remember that each patient only has one heart. So I think the narrative thrust is about the uniqueness of a story. I think what I found in medical culture is that diagnosis is anti-narrative. It's really taking this big story with complaints and strengths and personal, meaning making, and distilling it down to a diagnosis, one or two words that we act upon, which we have to do as doctors. But I think biomedical medicine has suffered for that, and I think this movement is bringing back story and the uniqueness of story to the field. And I always think that that's important to us because it leads to reflective capacity for the practitioner. And we know that reflective practitioners take better care of their patients, but they also take better care of themselves. So there's a win about that renewal, I call it, reflection and renewal and narrative. And I would say the arts and medicine in general bring us that reflection and renewal. I'd say that we're in a very anti-narrative time. That Twitter, now X, is about distilling to, how many characters. And in the examining room, we've all been forced to switch to the electronic medical record, which means that you're looking down, you're not paying attention necessarily to the person in front of you. New forms of propaganda, hate speech, fake news, so narrative is under assault. And I think part of the role that storytelling plays in medical culture is keeping us honest. And I think we enjoy a good critical dialogue with humanities scholars from literature and medical history and philosophy and theology and bioethics. I call them medicine watchers. I think they keep us honest because they push back at what they see of our culture. And I think if we're serious about what we do, we take what they tell us very, very seriously.
I'm really struck by this idea of keeping us honest for people who work in healthcare, and the way that training and medical culture can sort of narrow our lens. And I was reading an old interview with Rita Sharon recently where she talked about this issue of burnout and how for her it wasn't the original intention of narrative medicine, but as you say, it was taken up so immediately by practitioners who were feeling the stress and cumulative impact of doing clinical work in often difficult systems. So could you say a little bit more about how you see narrative helping build that resiliency you're talking about, either in yourself or people you've trained over the years? How do you think it might do that, or what might that look like?
Well, it's so interesting in the field of physician well-being. When I started looking at it with that Staying Human During Residency book, it was all about physician impairment. So the horse was already out of the barn. It was too late. We were talking about the mistakes, the errors, the unfortunate things that happen when physicians burn out. Then we moved into balance, life balance. Then we moved into well-being. Then we moved into resilience, which is part of your question. And now we're daring to ask the question, what about physician happiness? I think the field has really moved from impairment to what does it mean to be a happy human being as a physician? And the way I've had to sort of pitch health humanities and narrative medicine in various medical contexts, because there has been resistance. When I started this work, only 2 medical schools in Canada had any health humanities, medical humanities, arts, and health offerings. Now I'm happy to say that every single school does. They have both, mandatory lecture time and electives. But the way I pitched it was that narrative and the arts bring physicianly attributes. It's not hard knowledge, but narrative competence, reflective capacity, visual literacy, which is how to look and see. Um, did I mention critical thinking?
No, but that's
Critical
such
thinking
an
as
important
well.
one.
Where does knowledge come from? How is it constructed? Who gets left out? And wellness. And I think the wellness connection being that we're reflective and we think, what is the impact of this work? I think the other thing, so narrative medicine is based on two components. Well, it's expanded to more, and I'll get back to that. But close reading of literary texts and then reflective writing. We know that the close reading of literary texts enhances empathy for the reader. And that is not for a medical reader, that is for any reader who can commit to a text. And one of the pioneers of this work is at U of T, Professor Keith Oatley, who emeritus professor of psychology. He did some very elegant studies about reading literary text. We're not talking about pot boilers. We're talking about really well-crafted narrative texts, novels, short stories, how they increase the capacity of the reader to imagine another. And so reading expands your worldview. You're having to stretch your worldview. You're encountering your own judgments, blind spots, prejudices. You're engaging with characters you don't even like in places you'll never visit. So you really are expanding your worldview. And I think the ability to try and mentalize what's going on in a character does build empathy. So I think reading and exposure to the arts in general, it could be film, it could be theater, for some it's music, is about renewing that source and bringing us to a point of empathy. The second component of narrative-based medicine that's been emphasized is reflective writing. And, the writing, it's sort of three, as Rita Sharon describes it, there's attention, representation, and affiliation. So when I've asked, as you, Karen, and Damien have in your teaching, learners at all levels to write a story, they give them a prompt like write about a goodbye. We give them some parameters. More often than not, I find that these clinicians of all stripes, junior and senior, are writing about unmetabolized stories. So I think we as clinicians all carry the story that weighs on us. And it might have been an error. It might have been about the hidden curriculum and not speaking up when something wrong is happening. But I think the capacity to be able to write on those unmetabolized stories and then to share it. So, in other words, you're paying attention to a story that matters to you. You're representing it on the page. And then it's an act of affiliation that you're sharing these stories in a safe space where certainly your colleagues have had similar encounters. And so you're kind of taking a deeper dive into what happened. And so I think narrative is such a reflection, narrative writing is such a useful tool because it gets you to ask, what happened here? What went well? What really didn't go well? And what would I do differently? And so I think that arms you. It's sort of an inoculation for difficult stories to come. So I think, there's reflection and renewal, and then there's a processing of stories and an ability to step back and ask what happened here, which is what we do when we read a story. What happened here?
It sounds like humility is an important word here, both in what you were saying earlier about what physicians have to learn from the humanities, but also in how you're describing the writer's experience in front of, as a writer, before the things that they don't understand and can't quite process and can't quite
Yeah. Well, we
resolve.
speak of narrative competence, which is the ability to really work effectively with story, another person's story. And then there's narrative humility, a term coined by Sayantana Dasgupta. And it really means, you might not, you literally and figuratively, you might not be on the same page as your patient. You're not using words in the same way. Perhaps you recall that first scene of the film Wit with Emma Thompson, where it's a very unpleasant encounter, and I encourage everybody to look at it. But the doctor uses the word insidious, and the patient in front of him is a literary professor. He gives his definition as cancer as insidious, and she says insidious is treacherous. So I think I learned as a psychotherapist that you're always checking in. Did I hear that right? Or could this be another way of saying that? That it's a humble receiving of the story, not assuming that you've heard it right, that you got it right. It's this kind of co-construction over time. And we know that people tell stories differently to their hairdressers and their loved ones than they do to any clinician. So the whole clinical lens can shape and misshape the story. So narrative humility is really about you tell me. I want to make sure I get this right, and I think it's vital. And everybody talks about advocacy in healthcare. I don't think you can advocate unless you're humble. And I like the motto of disability studies, which is not about us without us. So if you're going to try and represent our stories for your end, we certainly need to be part of that. And I think increasingly in medical schools, nursing schools, they are using patients as educators. Patients, this is my story. And there's some excellent YouTubes. Any condition you can think of, you can actually find a patient narrative. And the New York Times has a repository of these as well. People talking about, certain illnesses, and it brings it to life, actually. And it gets you thinking differently than just the diagnostic checklist.
Can you tell us a little bit about the work you're involved with right now around bringing narrative to the issue of grief and loss? That's such an important area in healthcare as well. I think that hasn't always been, fully addressed, whether that's from the point of view of patients and families or healthcare practitioners. So can you talk a little bit about that?
Well, in the last few months, the National Grief Alliance has launched with some government funding. And what it is it's kind of a repository of all the grief resources in English and French and other languages across the country. Because as we know, people work in isolation and there's no point reinventing the wheel. So this is just a wonderful initiative that's going to help a lot of people, terrific advisory board. But I'm currently working on a list of poetry and fiction around loss. For that same reason that when you're in the midst of grief, sometimes you can't find words for what you're feeling. Or you're having conflicting feelings. You're having a bunch of feelings at once. That you're angry at the person and yet you miss them terribly. I mean, grief is just such a unique and complex story for each of us. Yeah. So I think it's of great help to be able to read, say, a very moving poem or a short story or even a novel about someone who's experienced a loss, because it helps you find words for your own loss, I think. And after a personal loss, I read poetry on loss every day for a full year. I guess it was almost prayer-like, but I was looking for the range of what people live and feel, which is huge, and words to articulate some of it. So personally, I found it very helpful, and I'm hoping that such a list will help other people And, there are many forms of loss. It's not just death of somebody. It can be, loss of a career, or etc. But I think this is another good example of narrative having therapeutic benefits. And, there's the whole field of bibliotherapy, which is, a field in and of its own right about being prescribed certain texts. These will be suggestions, not prescriptions.
Could you talk a little bit about the therapeutic use of writing in your own practice? Because I know you have a long history of offering narrative competence, therapeutic writing groups. Can you talk a little bit about that area of narrative-based medicine?
Yeah, and I think that's been one of the highlights of my career because, I'm a staff psychiatrist at Mount Sinai. I've been there over 25 years, and I did general psychiatry, but my primary role was to be a psychiatrist in the HIV psychiatry clinic there, which is Canada's oldest clinic for those infected and affected by HIV. So we were hearing a lot of stories. When I started the work, people were dying. Then the medications came, and literally like Lazarus, they picked up their cot and walked and had to rebuild new lives. Just the most powerful stories you can imagine. So a colleague, Julie Han, whom you know, Karen, a terrific occupational therapist and psychotherapist, she and I created a narrative group whereby men and women living with HIV could write their own stories about that experience. And we eventually published this book called Still Here, a post-cocktail AIDS anthology, because there had been a lot of anthologies about people dying. But when the antiretroviral cocktail came out, people suddenly came to life in certain ways and had years ahead of them. And so we were starting to hear these stories. But what was so interesting is the way we designed it. We consulted with a professor of English at U of T called Guy Allen about how do you get people to write in a safe space, in an authentic manner? How do you cultivate their own voice? And so, we found a way to do that. But we would give prompts. So write about a goodbye. And that could take you anywhere. We didn't insist they write about HIV. It could be death of a pet. It could be, a breakup. So we found that giving a wide open prompt was very helpful to them. We invited them to try and write a story with a beginning, middle, and end, because that helps you shape the story. And when you shape a story, I think it means you kind of take a stand on the story. You're having to try to make meaning and pull things together in a way perhaps you hadn't. And, not to give a journalistic report, but to kind of like a cinematic description of what happened, what they saw, and incorporating the senses and what they felt about what happened. And the stories were just incredibly powerful. And they told us time and time again that getting it on the page got it out of their head and was helpful to them. And some of them would share this with loved ones. Like, maybe we haven't talked about this, but this is what it was like the day I got my diagnosis. The idea that stories live on. But I remember one of the participants said, I stopped thinking of myself as a patient, and I started thinking of myself as a writer. So how more healing can you get than that, right?
Yeah, that's amazing.
Last question, Alan.
Mm-hmm.
Just wondering what you're reading these days, or if you have any recommendations for the lab or more generally.
Yeah, well, I'm a big poetry lover, so I'm reading the collected works of Louise Gluck, who just died, and she had won the Nobel Prize in the last year. And so I really there's something very raw and honest about her work. So I work away at those. I just finished, I like to read about spirituality because that's about meaning making and very broadly defined. But I just finished a book called Sacred Nature by Karen Armstrong, which is how we've all lost touch with nature and why that happened. And one of the clues is when we started thinking monotheistically, nature became something to master and dominate rather than a source of learning. So I really liked it, and I encourage you to read that because we're talking about renewal, and another source of renewal for so many of us is blue space and green space, being near water, being in woods. So I think human beings are wired to be near water and woods, and we are creatures wired for story. And that brings us back to why we're having this discussion, because we are wired across culture for story. And it's so nice to be able to bring that into, a clinical sphere.
It's been a wonderful conversation. Thanks so much for being with us
Well,
today.
thank you for having me.
Thanks, Allan. And thanks for bringing your relatives into the conversation, too. I'm going to carry the story from your aunt.
Oh, my God, yeah.
And the things that really impact on us as clinicians beyond our training and our professional experiences. So thanks for sharing that.
Oh, my pleasure.